Hello dear viewers, in this video I will be discussing induction agents for rapid sequence intubation or RSI. I am Dr. Sunil Garg from Essentials of Acute Care. Before we discuss induction agents, let me discuss about RSI. Means what is RSI? Please note that information discussed in this video is up to date and information may change in future as more evidence accumulates. RSI is a standard of care in emergency airway management for intubations not anticipated to be difficult. If intubation is anticipated to be difficult, paralytic agent is not given and sedated look or awake look is done. In rapid sequence intubation, there is virtually simultaneous administration of a sedative and a neuromuscular blocking agent to render a patient rapidly unconscious and flaccid in order to facilitate emergency endotracheal intubation and to minimize the risk of aspiration by minimizing the duration of patient apnea and the time airway is unprotected. RSI is particularly useful in the patient with an intact gag reflex, a full stomach, and a life-threatening injury or illness requiring immediate airway control. Induction agents are integral to the performance of rapid sequence intubation. They provide amnesia, blunt sympathetic response, and can improve intubating conditions. Etomidate is frequently used for RSI. It is given by intravenous push or bolus dose in a dose of 0.3 mg per kg with a time to effect of 15 to 45 seconds and a duration of action of 3 to 12 minutes. It is hemodynamically neutral and does not stimulate histamine release. The relative hemodynamic stability associated with etomidate makes it a particularly useful medication for the intubation of hypotensive patients as well as for patients with intracranial pathology when hypotension must be avoided. It provides no analgesic effect, so it does not blunt the noxious stimulation of the upper airway during laryngoscopy and intubation. For patients in whom this is a concern, like patients with cardiovascular disease or elevated intracranial pressure, an opioid analgesic such as fentanyl is often given during the pre-treatment phase of the RSI. However, all sedative agents including etomidate have been associated with post-intubation hypotension, especially in patients who exhibit hemodynamic instability at presentation prior to RSI. This highlights the importance of pre-intubation resuscitation. The concern with etomidate include adrenal suppression, myoclonus, and evidence of regional cerebral excitation determined by electroencephalogram after intubation. Etomidate is safe to use for the induction of the patient with seizures or even refractory status epilepticus. It should not be used as an infusion or in repeated bolus dosage for maintenance of the sedation after intubation. Midazolam is the most rapidly acting benzodiazepine commonly used for rapid sequence intubation amongst the benzodiazepine group of drugs. The induction dose of midazolam is 0.1 to 0.3 mg per kg IV push with a time to effect of approximately 30 to 60 seconds and duration of action of 15 to 30 minutes. It does not provide any analgesia but does possess anti-seizure activity, making it an effective agent for RSI in patients with status epilepticus. It is important to understand here that the dose given for the RSI of midazolam is more than the dose required for procedural sedation. Midazolam can be used as an infusion for the long-term sedation. Ketamine is unique among sedative agents or the induction agents in that it provides analgesia along with its amnestic effect. Ketamine is given in dosage of 1 to 2 mg per kg with a time to effect of 45 to 60 seconds and a duration of action of 10 to 20 minutes. Ketamine preserves respiratory drive and has both sedative and analgesic property. This makes it a good choice for the awake intubation attempts when laryngoscopy is performed on a patient who is moderately sedated and topically anesthetized but not paralyzed due to concerns about a difficult airway. Ketamine is among the most hemodynamically stable of the available sedative induction agents, making it an attractive choice for the hypotensive patients during RSI. Propofol causes sedation and amnesia. Induction dose of 1.5 to 3 mg per kg can be used with a time to effect of approximately 15 to 45 seconds like etomidate and a duration of action of 5 to 10 minutes. Propofol does not provide analgesia. In addition to its use for the RSI, propofol is also used for the long-term sedation in critically ill patients, sedation for brief procedures, and induction of anesthesia. Propofol reduces airway resistance and can be a useful induction agent for patients with bronchospasm undergoing RSI. Its neuroinhibitory effects makes propofol a good induction agent for patients with intracranial pathology provided they are hemodynamically stable. Propofol suppresses sympathetic activity causing myocardial depression and peripheral vasodilation. A decrease in the mean arterial pressure caused by propofol can reduce cerebral perfusion pressure, thereby exacerbating a neurological injury. The usual decrease in the mean arterial pressure is approximately 10 mm of mercury, but severe hypotension can develop in patients with underlying hemodynamic instability. Serum triglyceride and serum lipase rise during propofol infusion. Now we will discuss the choice of agents in different conditions. So first we will discuss the choice of agents when there is increased intracranial pressure. In the patients with potentially elevated intracranial pressure, like patients with head injury or stroke or other conditions leading to increased ICP, adequate cerebral perfusion pressure must be maintained to prevent secondary brain injury. This means avoiding significant elevations in intracranial pressures and maintaining adequate mean arterial pressure. For these reasons, etomidate is optimum choice for induction of these patients and ketamine is a reasonable alternative. In the severely hypotensive patients, a reduced dose means 25 to 50% less than the standard dose of either etomidate or ketamine may be used in addition to appropriate pre-intubation fluid resuscitation and vasopressor administration. In patients with status epilepticus, either propofol or etomidate be used for the induction of RSI. Midazolam may be used, but its slower onset make it less desirable than propofol or etomidate. But if the patient is hemodynamically not stable, then either etomidate or midazolam can be used. For hemodynamically stable patients with severe bronchospasm requiring intubation, either ketamine or propofol be used for induction because of their bronchodilatory properties. Etomidate is an acceptable alternative, but in hypotensive patients, either ketamine or etomidate is preferable. None of these agents causes histamine release. Etomidate is preferable for induction of the patients with significant cardiovascular disease requiring RSI. The hemodynamic stability it provides and the absence of induced hypertension make it preferable to other sedatives. In patients with coronary artery disease or suspected aortic dissection, Give fentanyl 3 microgram per kg slow IV push as a pre-treatment agent to mitigate the catecholamine release associated with the laryngoscopy and intubation. All sedative agents can cause hypotension when administered to patients who are hemodynamically unstable, including ketamine. In addition to pre-intubation resuscitation, to maximize cardiovascular physiology like fluid resuscitation and vasopressor therapy, the dose of sedative agent should be decreased for induction of the patient in shock requiring RSI. Use IV etomidate 0.15 mg per kg or alternatively IV ketamine 1 mg per kg. Both agents cause a small drop in the mean arterial pressure in patients with severe hypotension but less than other sedative agents. In general, if the clinician anticipates a difficult intubation that may preclude successful RSI, an awake look or sedated look is advised. The clinician may then decide to use an appropriate sedative or combination of sedatives and topical anesthesia to facilitate laryngoscopy and assess the airway and allow the clinician to verify that laryngeal structures are visible before committing to paralysis, while allowing the patient to maintain their respiratory drive and protective airway reflexes. This approach is referred to as sedated look or awake look. The topical anesthesia, nebulized 4% lidocaine along with moderate sedation is used. Ketamine is gaining popularity in these circumstances because it allows for the patient to maintain respiratory drive while providing analgesia, amnesia and sedation. Ketamine's analgesic property allow it to be used as a sole agent in the bloody traumatized airway when topical anesthesia is unlikely to work effectively. So to summarize, rapid sequence intubation is used for the patient with intact gag reflex, likely full stomach and emergency airway management. There is virtually simultaneous administration of sedative and paralytic agents. Etomidate is preferable in most conditions, while propofol and ketamine is preferable in patients with reactive airway disease. Pre-treat with fentanyl if etomidate or propofol is given for RSI in patients with significant cardiovascular disease or patients with increased intracranial pressure. Ketamine with topical anesthesia is given or it's a choice for sedated or awake look when intubation is anticipated to be difficult. Here I finish. Thanks for watching this video. If you have any feedback, suggestions or comments, please write down them in comment section box. And please do not forget to subscribe to this channel. Till then, bye and take care.